Okay.
All right, everybody. Good evening. Thank you for joining our Men's Health webinar. My name is Preston Brickner. I'm your host for the evening. Just going to start off with a few housekeeping items, and then I'll turn it over to our speaker. First off, your attendance tonight is completely anonymous to all the other attendees. No one will see your name nor your face. Any comments and questions will only be seen by myself and our speaker. If you wish to ask a question, you may only do so tonight by typing in the chat box. That's at the bottom of your screen. It looks like a little cartoon bubble. At the end of our talk, we will save as much time as we can and try to answer every single one of them. Feel free to type them in whenever, but we won't get to them till the end. Our presentation tonight should last approximately 1 hour with those questions and answers, and it is being presented by Dr. Jason Engel. Dr. Engel is a board-certified urologist at the Urologic Surgeons of Washington. He received his medical degree at the University of Pennsylvania and then went on to complete his surgical and urology residencies at Northwestern University in Chicago. Thank you for joining us tonight, Dr. Engel. I know your time is very valuable. Why don't you take it away, sir?
Okay. All right. Okay, so it looks like we have a decent crowd here. I've given this talk lots of times, and mostly we send it out to our patients here. So I can imagine that we used to have really big crowds, and they're still reasonably fine. I am combining two different topics that there are actually separate lectures, and you're going to hear me say over and over again. You're going to hear me plug my website, dcurology.net. Now, whether this one ends up being recorded and put there or not, there are lots and lots of different educational webinars that you'll be able to find there, not just at these topics, and you'll find these topics as well. So we're going to talk about erectile dysfunction, and we're going to see how many people will stay on. I mean, that's kind of a ubiquitous problem as people get older. We'll talk about that. And then we're going to talk about a more limited topic, kind of a throw in, male urinary incontinence, male stress urinary incontinence, and how I fix that. So let's kind of dive in. That's me. You've already heard about me. My history is I was a GW for a really long time. I was the vice chairman. My big thing is robotic surgery. And in that, I certainly know a lot about erectile dysfunction. And I know a lot about incontinence because I've made a lot of people have trouble in those two areas by doing prostatectomies for prostate cancer. So we'll talk about that. Boston Scientific is kind enough to kind of host this, and Boston Scientific is the great company that has these devices that we use, these technological marvels that we use for some applications in erectile dysfunction and incontinence. And so they have these great websites. There's this ED Cure. It can talk about, teach you a lot more about things. But of course, I'd rather you go to my website, dcurology.net, dcurology.net. So let's talk about erectile dysfunction. These people obviously are not suffering from that problem, perhaps. Let's talk about how you get an erection, because if you understand how a person gets an erection, the rest of the talk kind of makes sense. So I always talk about the penis as being a triple-barreled shotgun. And, so if you look at this here and you look at, a penis in cross-section, there's these two bodies called the corporal bodies. Those would be the shotgun barrels, and those fill up with blood when you get an erection. There's a third one that you urinate through, which is at the bottom. Your urethra is in there. That doesn't totally contribute to the erection too much. It gets the head of your penis hard, but the action is in those two corporal bodies. And the concept is, you have to have the horny signal, the aroused signal from your brain that tells your spinal cord to go ahead and send messages to the arteries in your penis to dilate. The arterial blood goes in. The veins in your penis are on the outside of your penis. So it's almost like an internal tourniquet where they get smushed. They get smushed such that it's like putting a tourniquet on there. The blood stays in. And actually, you don't just lose an erection. There's an active process from your spinal cord to tell the arteries to now stop being dilated. That lets the blood come out. The veins can drain everything and you're good. So any part in that process can be an issue. You could have a problem with the nerve signals to the erection. You could have a problem with the arteries. And sometimes you can have a problem with the veins where for some reason they won't compress. We call that venous leak. We won't talk about that too much. So that's erections. What causes erections? Now, everybody really talks about, specific patients always want to know exactly what's causing my problem. I mean, the first thing patients generally don't understand, because I don't think anyone advertises this to you in your golf foursome or at your cocktail party, is that everyone else is having the same problem typically. It's a problem that kind of comes on, and there doesn't have to be an exact answer. Okay. We like to talk about exact answers like diabetes, like it must be a blood flow problem for you. Surgery or trauma is something I know a whole lot about, things like that. But the most common cause for erectile dysfunction is, I'm just going to say, is aging, period. It's just something that's so unbelievably common in aging studies that I say to patients, it's more of an aging problem. It doesn't mean necessarily we have to find, here's the problem, we're going to fix your medical problem, that's going to fix your erections. It just kind of doesn't work like that. So let's go down the list here. So a lot of these things you're going to notice come with getting older. You're not as happy as you used to be. You're fatter than you used to be. You lie around. Is that the direct cause, or does that just mean it just means you're getting older? Diabetes is something we can hang our hat on. We can talk about that later. But I would tell you that that's the vast minority of patients that I see that talk about their erections. The vast minority, not 30%, are going to be diabetic. If we include people with a little bit of a bump in their A1C, that's different. But the standard insulin dependent diabetic, that truly is somebody that generally has trouble with their erections. Not so much. And when we talk about vascular, that doesn't mean this is a person that has pain when they walk down the street and they're getting vascular surgery. People don't have as good blood flow as they get older. So I tend to, the bottom line, and smoking is a blood flow issue. So I tend to just dumb this down for patients and say, what comes with aging is what's going to cause you to have problems. And generally it's a blood flow problem, not so much a nerve problem, not so much a vein problem. Whoever's here knows that, suddenly when you start having the trouble, the first thing is, who do you talk to? Who are you going to tell you have this problem? Are you actually going to tell your friends that you have this problem? Probably not. But it's a big deal. And the more people know that, look, if you knew that everyone else has the problem, it's less of a big deal. I always say to patients, why do you think everybody knows what the name Viagra and Cialis is? It's because it's so common. It's crazy. But, when it first starts to happen, it's usually a problem because the partner wonders, what's wrong with me? Is there something wrong with me? They start talking to the man about it. That only makes it even harder to perform. And obviously we haven't talked about the psychological aspect of the whole thing, but the psychological aspect of it, once it starts getting in your head, maybe you failed, you've actually couldn't achieve orgasm and you failed and quit. Once that happens, it's in your head and it makes erections after that even 10 times harder. So we'll talk about that, but it's true. It's not something people talk about. So you're not alone if that's what's happening. I tend to just brush over the diabetes thing because, again, if you're just a heavier guy with a little bit of an A1C issue that your doctor's talking to you about, that's not why you have diabetes. There we're really talking about the insulin-dependent person that has pediatric diabetes, and that's a crippling problem for blood flow throughout your body, including diabetes. So I'm going to kind of jump through it, just letting you know that that's one of the things that contributes. Heart disease. People ask me about that. There's two tie-ins to heart disease to this discussion. I always say to people, have you ever seen a 60-year-old man win the Olympic marathon? You have not seen that. It's just, our bodies are cars. They don't work as well when they're 60 as they do when they're 20. It's that simple. And one of the main reasons is just you don't have the blood flow that you used to. There were a lot of studies that kind of suggested that if you have erectile dysfunction, you should go get screened by a cardiologist. That means you're going to have heart disease. Aging people have heart disease. That's how I view it. And I don't really see this one-to-one. So I'm not so much in tune with the concept of heart disease as being the issue. Certainly if someone says, hey, I'm on 4 antihypertensives, I've had a heart attack, and yes, that person has bad blood flow and they'll have trouble. But Pfizer kind of came out with a study early on that kind of link the notion that you may have heart disease. They also sell cardiac products, by the way. So they wanted you to see your cardiologist, but I'd rather just call most erectile dysfunction. And I'm going to say 90% of the people I see that haven't had a prostatectomy, it's just an aging phenomenon. So you don't have to worry that you're going to have a heart attack. But this is in the Pfizer study that really talked about this, and people said, "Oh my God, if ED is it starts in 70% of cases where ultimately the person has heart disease. Oh my God, I better go see that." I think that's kind of fallen away, and I don't really preach that to my patients because I think it's more of an aging thing. Now, in terms of reducing risk, people will say, "What can I do to get better erections?" And the answer is nothing that's linear. The answer is you do this, you'll get your erections back. I've actually not seen that. But if someone says, "Yeah, but I think I'd like to lose some weight," I'm going to say, lose some weight. I work out every day. I do triathlons. Definitely lose some weight. There's a lot of benefit, but there's not a linear benefit. So the idea is, how do you reduce your risk? Well, be healthy. Sounds like a great idea to me. It's probably not the short-term answer to get your erections back, but it is definitely a great idea for me. And this is another controversial area, I'm going to call it low T. Low T is a phrase that also was coined by the pharmaceutical industry. There was a period of time, this is about 7 years ago or so, I might be wrong about that, where all these drug companies started to not create new forms of testosterone, but rather what they were creating was new delivery systems. So now there were gels you could rub on your chest. There was stuff you could put under your armpits. There were pellets you could put in your arm. And what was patented were the delivery systems, not the testosterone. And when there's expensive drugs, there's going to be a market, and they're going to create a market. And suddenly there was this diagnosis of low T that was created by the pharmaceutical industry. So men will come in saying, "I have low testosterone. That must be why I have bad erections." And I actually find that to be a harmful message, because giving that man testosterone generally has nothing to do with their erections. The average man that's older, that's a little upset, that's a little bummed out, maybe he's bummed out because of his erection problem, they generally have a testosterone that's just below the normal limit. But I did some research into this. The normal range for testosterone is actually generated by young men. And young men have higher testosterone. So when someone comes in with a testosterone of 270 or 260 and they say, "Well, I have low T," what I'm going to say is, no, you're just older. It's a normal thing. When a man says, I have low testosterone, I ask them, what problem do you think is being caused by that? If they say, "Well, I also have problems with my erections," we talk about the things we're about to talk about to help him get erections. I don't talk about his testosterone. That's not really the answer. So I kept this slide in because I thought, all right, let's talk about this. So symptoms of low T, okay. Now there's low T, meaning you have almost no testosterone. And then there's the other 95% of people that say they have low T, which is just under the normal level for a 21-year-old. But let's look at some of these things. Reduced sex drive comes with age. Less happy with life comes with age. Concentration and memory comes with age. Increased body fat comes with age. So a lot of people, what was fomented by the drug companies was that, oh, it's not that you're getting older, it's that low testosterone is the source of all your trouble, so you need to spend thousands of dollars for that. We're doing an ED talk, so my point of this is just to say it's not going to be your testosterone unless it's extremely low. If you truly are having your hair is falling out, your testicles are shrinking, you're having signs that you have no testosterone, that's a different population. That's a very rare population. The average person that thinks that testosterone is their problem, it's not their problem. It's that they just need to succeed and get erections. So that's my point of leaving that slide. And now here's something I know a lot about, which is prostate cancer treatment. I've given a lot of talks today to patients with prostate cancer, and they're going to do surgery. And I tell them all that you're going to lose your erections. And so This is an area that if I've done 3,000 prostatectomies, so I have a lot of patients that need this help. And the mechanism of action there is that the old-fashioned thinking, in my opinion, was that the nerves to erection are damaged, and it's the nerves that have to regenerate, and that's the issue. For me, it's a blood flow problem. So for me, the likelihood that somebody's going to get their erections back has everything to do with what kind of shape are you in beforehand, i.e. blood flow, what sort of erections do you have beforehand. But the point is that everyone that goes through prostate cancer treatments, particularly contemporarily, because even radiation now gives you what's called hormone therapy, is going to have to deal with this problem. And it's usually a more severe problem than the typical patient with erectile dysfunction, who's going to say, I'm starting to have a little trouble. I can't rely on my erection. And then it's now I've actually failed with my partner. Then it's now I'm really having trouble. Then I've tried pills. We'll talk about this progression. And now pills don't work. So but the prostatectomy patient is going to go directly from that. It's not going to have that slow progression. They're going to have the severe, they're plunged into severe erectile dysfunction. So they're going to be using more severe remedies at first. And now this is a small subset. I don't know if any of our audience even have this problem. Peyronie's disease is a scarring of the penis that happens. We generally don't know why it happens, but it's theorized to happen because as a man gets older, his erection isn't as hard. And if it's not as hard, then what happens is there may be some bending involved when he has intercourse, and that bending, your body senses that as injury, and it lays down scar. And when it lays down that scar, it tends to cause curvature. If the scar is severe, then it blocks those corporal bodies and then impairs blood flow as well. So if Peyronie's disease and erectile dysfunction goes hand in hand, either it's because you didn't have a good erection that your penis was bending and you caused the scar, or it's the scar is so bad that now it's causing erectile dysfunction. 90-something% of the cases are the former. Sometimes it's the latter. Most people that come in saying I have Peyronie's disease, I'm always asking, are you here for a bent penis, or are you here because you have problems with your erections? 90%, it's really the problems with the erections. Patients tend to have a psychological tendency to try to, say it's not that I'm old and it's not that I'm lesser with my erections. It's that I have this problem causing it. That's where the low T came from, and the Peyronie's too. My underlying philosophy is, it doesn't matter what it's from, you just need success and you need your erections back. So when someone comes in talking about Peyronie's disease, I'm going to determine, let me see a picture of that. Let me see how bent that is. I want you to show me that you can get a great erection. And if you can't, then I know we're really talking about your erections. We're going to get you a good erection. And I say, once you have a good erection, you can come back if the curvature of your penis bothers you. And 9 times out of the 10, it does not. But the reason Peyronie's disease is very much in this slide is when we talk about penile prostheses, that tends to be how we treat that when a man also has erectile dysfunction with Peyronie's disease. And I'll just touch upon this. Peyronie's disease is that curvature. Why don't you guys just sort of remember that if you have Peyronie's disease and you don't have good erections, we're going to talk about penile implants, which I'm about to get to. If you have Peyronie's disease and you get good erections, we tend to either observe. I actually don't use oral medications much because it doesn't help. I sometimes do surgery to fix the curvature. We're not really talking about that today, but the intro into this talk is penile implants. Okay, so that's the background. Take-home message. We've talked about some specific scenarios of diabetes and vascular disease, and we've talked about heart disease, and we've talked about Peyronie's disease. But again, it's typically just you're getting older, it's getting harder. Maybe you've been married to somebody for a long time, and you just need help. So my goal is, let's just get you an erection and not worry so much about the cause. The less you worry about the exact cause, the happier you'll be if you just have success. I always say what you need is success. That's the bottom line. So here's like a basic summary of what the options are. We all know about Viagra and Cialis. That's pretty much what's out there generically. There used to be other things, Stendra and Levitra. Nobody really uses those anymore. They're really cheap now. I certainly remember the days they were $60 a pill, and it's a big hassle to deal with that. We used to have patients get prescriptions from Canada, all kinds of things to help them. Vacuum erection devices, somebody asked me about that today. Again, that used to be something that was probably more, well, again, a lot has to do with economics. Vacuum erection devices used to be more popular because there was this like loophole that the VED companies would use from the lobbyists getting this legislation passed, that Medicare would pay for vacuum erection devices in the same manner that they would pay for artificial limbs, for instance. So it was very lucrative. So people use them. I don't really know anyone that uses them anymore. It's something that you put over your penis like this. You get it on Amazon now. And what it's showing here is that it sucks venous blood in. So it's not like warm like a regular erection. It's not the same thing. And you have to put a band there to keep the blood in. So it's not at all ideal. I try to tell patients that the next step, if pills don't work, or if they did work and then they become not working, which this is another thing most men don't know, that if you're already on pills, there's going to be a point it doesn't work, because this is a progressive problem. It's not, I have the problem and it stays that way. It always gets worse. And that's not analogous to maybe hypertension. Maybe hypertension doesn't always get worse, or other things don't. This always gets worse. So if I have a young enough person on pills, there will be a point where it stops working and they have to decide, what do I do now? And I'm going to tell them to do injections. We teach a lot of people to do injections here because it works. Injections work. Injections gives you a warm erection. You don't have to have this band around the base of your penis or anything like that. It sounds draconian that you're injecting your penis, but it's actually very easy. It's like a diabetic injecting himself. You do it yourself. We teach you, you find the dose, and it works. So, most of my patients are going to have injections. And the vast minority of patients will ask, what do I do if I can't do injections, or it's not working well, or I just can't do it. I tried it and I just can't do it. Then we move on to penile implants, which we'll talk about. But I actually won't offer a penile implant to somebody who hasn't at least tried injections, to make sure they're going to be happy with that. Okay. This might be the first time you're hearing about injections, but I can certainly tell you that millions of men do injections. And if you listen to the radio much, if you listen to a news station or a sports station, something that's guided a little bit more towards men, you're going to hear about these erection clinics that guarantee success and blah, blah, blah. They're just rip-off places that are selling injections for $1,200 when they don't need to be. So it's way more common than you think. Everyone knows about Viagra and Cialis. Nobody advertises to people or jokes about or injections at a party, but believe me, it's out there. We've talked about this. We've already talked about, why wouldn't it be a good idea to quit smoking? If someone says, hey, if I quit smoking, will I get my erections back? I say, not necessarily, but if that's what you need to motivate yourself, that's good. Same with losing weight, same with getting in shape. So, but it's not a one-to-one. Psychotherapy, I'd like to talk about that. Like, well, it's a performance anxiety issue, or it's, my wife said something, or my partner said something to me, and and now it's I have a hard time. I can masturbate, no problem. I can do, but I can't perform. That's performance anxiety. And the two options are either to succeed with something like pills, or to delve into it with psychotherapy, or psychological counseling. I don't think psychological counseling makes any sense. I mean, we sell pills in the office for $1 a pill. It's really easy to get at the pharmacy if you use like a coupon called GoodRx. So I think you can go for a long drawn out session with a psychologist, but the reality is you just need to succeed. I always say the best psychology is success. And so I don't normally refer people to a therapist to talk about their erections. I think it's counterproductive. Medicines, how do they work? They are indirectly causing that signal. They're taking the nerve signal to the penis and they're extenuate. It's like a car amplifier a little bit. So it's not going to just force an erection. There has to be the signal. There has to be the basic mechanics. It's going to amplify the signal. One thing that people don't know about pills, Viagra, Cialis, et cetera, is that they only work 60 to 70% of the time. They don't work 100% of the time. And the second thing I've already mentioned, if they do work, there's going to come a point where they don't work. So whatever your dose was, you're going to have to go to a higher dose. And then eventually you're going to have to come to that place where you have to decide, am I willing to do injections? Everyone will try pills. Not everyone's going to try shots. Trying shots means this is important to me. I really need to do it. Trying shots often means I'm going to talk to my partner about this and for the first time say, this is very important to me. But I very much encourage it. We've already talked about vacuum erection device. I can't really remember the last time I told someone to do this. I actually wrote the definitive paper about vacuum erection devices after prostatectomy as the potential of, hey, what if you did this every day? You know, would that help your penis? And the answer was no, not really. And it doesn't even work until you start to get some of your function back. So I'm a big shots fan. If you have to come to it, but some people just can't do shots and they won't do a penile prosthesis. So this is an option. It's a lot cheaper now. We're not talking now about something you get in kind of like a sex shop that's super cheap. These things are kind of medical grade. They come with like support. They have CDs. This is how you do it. You can call someone if it's not working for you, that kind of thing. But I still just think it's a lot easier to do shots. And this is shots. Some people can get a little scarring with shots. That would be one reason to do a penile prosthesis. The number one thing about shots is we've all heard about the 4-hour erection. Everyone jokes about the 4-hour erection. That came from the Cialis campaign when it first came out because Viagra was first to the market. So they had to kind of come up with another byline. That never happens with pills. I've never heard of anyone, maybe someone with sickle cell, but I've never seen it, has a 4-hour erection with shots, but they mentioned it in their commercials, even though they didn't have to. The FDA wouldn't have forced them because they wanted people to think it was more powerful. What can cause the 4-hour erection is shots. And everyone says, wouldn't that be great, a 4-hour erection? And I can guarantee you there's no one that's ever had a 4-hour erection that thinks that's great or thinks it's funny in any way. It starts to become painful. You have to go to an emergency room. It's embarrassing. And it can cause damage. But that's why we make everyone do it in person here. We'll have them watch a detailed tutorial, and then it works. So they do a very low dose shot here. We have a great nurse practitioner that shows you, and then you kind of titrate the dose up and find out what's the sweet spot where it lasts long enough for you, but not too long, but it's still very hard. And that's shots, okay? It doesn't have a high rate of people doing it over and over. The cost is not an issue with shots because it's generic. It's not covered by insurance, but it's actually pretty cheap. It's probably averages out to something like $2 a shot, something like that. Certainly a low price to pay to get an erection. People don't like shots because they just can't get around it. It can be actually a very spontaneous thing. We usually teach people to draw up their dose in the syringe. Don't suck it out of the vial each time you want to have intercourse. That just looks weird. Don't do it in front of somebody. Just freeze the syringes, thaw it out. It takes like 10 seconds to thaw out. Go to the bathroom, do it, come out. It starts getting hard right away. But it's not for everybody. And when it's not for everybody, or if it's causing scarring, or if it's some people, they're so sensitive to the shots, they get a 4-hour erection. Then generally the next thing we're going to move to, so we're going to start with reassurance, and then we're going to start with pills, and we're going to start with shots, and then if that's no good, we go to penile prosthesis. So there might be a slide later about satisfaction rates, but penile prosthesis is not it's not a whimsical decision, but you know, and people say, oh my God, I'm going to be like the bionic man. It's so weird, but it's all internal. It just becomes part of you. I'll explain the procedure in a second. But in short, what it is it's an operation. It takes about an hour and a half to do. What we're doing is we have to sort of hollow out those two corporal bodies that aren't working well, but we have to kind of make space. And what we're doing is we're putting implants inside those corporal bodies that are going to get hard with water or saline, not with blood. And then you have to say, well, where does the saline come from? A balloon. This is showing this sort of round balloon. Now I use this flat balloon. There's two different ways to insert this. And then and then you say, well, how does it doesn't stay hard? It's soft. No one would know you had it. You'd be in a locker room. No one would have any idea you had it. But in your scrotum, there's like a third testicle. And then you squeeze it. It's usually about 10 times, and it just starts getting harder and harder. And it gets rock hard. When you're done, you still have sensation and all. When you're done, you press this button on the pump, and then it goes down. So it seems like a stupid thing that people would joke about, but it's really like an amazing bit of engineering. So we'll talk about the procedure a little bit more. The side effects of it are infection and erosion. So my patients all know. We're going to talk about this in the incontinence section. Infection and erosion. Infection and erosion. If you have an underlying problem, like you're an insulin dependent diabetic, you're at higher risk of infection and erosion. They tend to go hand in hand. If you've been radiated down there for some reason, whether it be prostate cancer or another reason, you have very poor blood flow, and then you're at higher risk of infection and erosion. In other words, the severe problems that can cause erectile dysfunction are because they wreck your blood flow. Bad blood flow is bad for fighting infection. Your body fights infection by sending white blood cells there to take care of things. And so it makes sense. But the rates of infection and erosion are nowhere near the rate that would cause you to say, I'm not going to do it. It's just patients need to be aware of it. And more importantly, I make all the patients extremely aware of it, because there's a way to salvage the situation if you start to get an infection in the beginning. In the old days, we used to think you had to take everything out. These days, we salvage the situation as long as you get to me early. So that's telling you about complications. But the complications have gotten less and less. The mechanical failure of this have gotten less and less over the years. I've actually seen the plant where they make these things, and it is pretty incredible engineering. The infection rate went way down since they started putting this chemical in the devices that's antibacterial. And I'm old enough to remember the days where they didn't have these things galvanized together, so you actually would suture them and they would pop off and you'd have to fix it. So it's not weird to have to go back and fix something like this, but it's not a guarantee that we would have to fix it at all. Okay, these things have been around forever. They weren't always owned by Boston Scientific. That's kind of a big company that buys other companies. And the patient satisfaction rates are extremely high. Let's see if I know how to make this work. Maybe I don't.
You just hit next.
Hit next.
Oh, go back. Or you should be able to hover in the bottom left corner. And click on that.
Trying.
Try clicking on the play.
That's doing nothing.
All
right, I'll narrate it. It's okay. All this really shows, so you see that this is a flaccid penis, and you see the bodies have been inserted here. This shows a pump, and I'll talk about the way I tend to do it. There's two ways to do it, and then either the partner as part of foreplay does it. That's what I tell people to do, or the guy does it himself. It's going to take this balloon, and this is sort of the standard way to do it. It's not how I do it. You put the balloon behind the pubic bone, you don't see it. And then it will make the fluid come out of here into these two things, and it'll get big. And then the idea is when you press this button, it goes back to the balloon. You give your penis a little squeeze and you're done. So it's very easy. It's no big deal. There's nothing to it. There is some aching involved. Your penis will ache for a couple of weeks, but it'll be all worth it in the long run. So that's good enough there. I do it as an outpatient. You see me in the office the next day. You're under anesthesia for it, so it's no big deal to do it. And the two different ways to do it are either an incision under the penis or over the penis. I think a little bit more expert or difficult way is to do it over the penis, but that's how I do it now. And that allows me to put the balloon up under where the muscles are to do sit-ups, and you'll never feel it or see it. It allows me to be less traumatic to the scrotum. So we usually let this thing heal, and then you come in and you usually meet the Boston Scientific rep that was in the case in my office, and now you have kind of a support mechanism with it, which I find invaluable. And the way I do it now, you tend to come in 4 weeks. If you make the incision near the scrotum, it takes 6 weeks, and then you're ready to go. You're good to go. This slide talks about cost, and so this is important. I try not to get people too excited about these things because these penile prostheses are expensive. They're covered by Medicare. So if I see a person's got Medicare, we're going to talk about the whole thing because I know it's covered and we're okay. If it's a private insurance, mostly we're talking now about the more restrictive ones, which are Aetna and Cigna and Blue Cross. I'm sorry, Aetna, Cigna, and United Healthcare. Oftentimes it's not covered. Blue Cross sometimes is covered. Blue Cross Federal, it's usually covered. And the problem is people say, I'm going to pay for it anyway. And the answer is, you probably won't. I mean, this is a $20,000, cost or something. So it is an issue. Unlike the incontinence, which it's always covered, it's not always covered by insurance. It is covered by Medicare. And I think everybody needs to know that. Pretty soon I'll be doing these at a surgery center, and it'll limit the cost somewhat if someone has to pay cash. But so that still is an issue in this department. It's not something where lobbyists are saying men have to be able to get erections. This is just saying that there's a very high patient satisfaction rate. As long as you don't talk people into this, these are motivated patients, and motivated patients are very happy to have a reliable way to have intercourse. So again, I guess this is just talking again about the downside. Here's that word erosion. Here's that word infection. And erosion causes sometimes the thing to move or migrate. And of course, it's like any device. Malfunction and failure is not common, but it's not uncommon after 10, 15 years or so. None of these things are a reason not to do it, though. I'll just let you guys kind of sort of read the small print. And that's erections. And remember, I have not talked about other treatments. I have not talked about things that don't really work. I've not talked about shockwave. I've not talked about stem cell. I'm happy to have you ask me questions about those things. I'm happy to have you ask me questions about over-the-counter remedies, Eroxon, people will ask about things like that. So if you have questions, at the end, I think some of the best conversation is from questions, but we'll see what we get later in the talk. So now, and remember, the way you do that is you go to the chat box. No one's going to see it. I'll see it. And we'll answer them all anonymously. So stress incontinence in a man. We're talking about male stress incontinence. So let's talk about that, because female stress incontinence is a different problem than male stress incontinence. And we have a separate talk, and I'm giving one in a couple of weeks or next week or something like that, on enlarged prostate. That can cause incontinence in a man, different kinds. Those are called overflow incontinence or urge incontinence. These are all different treatment mechanisms. So we're now talking about male stress incontinence, and by far the number one reason to have that is because you had prostate cancer treatment or some other rarer trauma down there that's causing your bladder neck, which is the bottom of your bladder, not to close properly. And so this is just a quick talk to talk about that, talk about the prevalence of that, and then talk about how we fix that. So stress doesn't mean you're stressed out emotionally. Stress means bearing down. So anything that causes you to bear down a little bit, which can include standing up, sitting down, bending over, passing gas, lifting something heavy, that's stress incontinence. Way more women have that than men. That just happens in women just from having a vagina that not supporting the bladder as much. And there's procedures for that as well. And we'll talk about that, but we're talking about men now. How common is it? It's common. How common is it in America? It's common because treatment for prostate cancer is common, frankly, whether it be radiation or surgery. And I'm going to go so far as to say over-treatment of prostate cancer was rampant in this country, and bad marketing for that treatment, particularly let's say at academic centers that say, come to our place because our hands are touched by God and we're going to do better than where you are. They don't tend to stress incontinence. They don't tend to follow their patients afterwards. So there's many men out there, not so much in my practice, that walk around with incontinence and they just get used to it because they don't know that there's an easy fix because the person that took their prostate out didn't really see them afterwards. So part of this is an outreach thing that I hope people hit my website from other cities that don't even go to me to know that there are easy fixes here. So let's talk about the urine. Let me see what the next slide is. Okay, so let's talk about how do you urinate? How does that work? So on the right here, it's not showing the kidneys, but the kidneys empty urine into the bladder. And how we're dry, this is what most people don't understand, is it doesn't have anything to do with the muscle that you squeeze voluntarily. How we are dry is because just like our anus, we're not constantly squeezing our anus to not, poop in our pants. And that's mediated by your spinal cord. It's telling your anus, hey, close, that's the default, is close, and your brain tells it to open. It's the same thing for your bladder. The default is it tells the bottom of the bladder, we call that the bladder neck. Sometimes we call it the internal sphincter. It tells it to pucker like an anus. And that's why I'm not leaking on myself right now. I'm not doing anything to achieve that. The reason a prostatectomy affects that, or the reason radiation, are two different reasons, but it's because here you see the prostate, and if I remove a bladder, if I separate the bladder from the prostate, the bladder is going to have stitches through it, it's going to have had surgery on it, and at first it's going to relax and not squeeze, and that's what causes the leakage, and then eventually when it senses that things have healed, it's going to close, and there's some men it doesn't close. At a year, if I've done surgery, or if someone sees me after a year when someone else has done surgery, unfortunately, it's not going to get better at that point. We have a decision to make, and that is either live with it, which is a shame, or get it fixed. Diapers these days and pads are just really good. It wicks the urine away from you, and you just kind of get used to it. So there's so many men that just say, I'm going to live with that. But once you see how easy the fix is, it doesn't seem correct to do. Now, radiated folks will get incontinence for a different reason, and that is it will radiate this actual tissue or radiate the blood vessels to this tissue such that it's going to scar it down. It's going to just keep it from opening and closing. It's now a fixed opening. So it's just a leak. It's the boat has sprung a leak. Different story. That also would be stress incontinence. And then there's rare situations where you have a spinal cord injury or you've had other surgeries for cancer that kind of hurt things. But those are the main reasons you're going to have this problem in a man. Again, the external sphincter, which we squeeze when we don't want to pee, we have to pee real bad, or we want to pinch it off at the urinal, that is never going to get somebody dry. That's what you're going to work when you do Kegel exercises. I use those Kegel exercises to make a man leak less after surgery, but it's not going to cause them to be dry. So that's the problem. Here again, it's just saying, what are the reasons? Very rare complication of enlarged prostate surgery would be incontinence. Same idea, you shaved out the bladder neck and for some reason it didn't close up. And so you see a common theme here, which is effect on your bladder neck. All this is saying is what I think is the obvious, which is most men are not happy about it at all, and they want to get that fixed. Now, again, I hadn't gone through, I probably would have deleted this slide. I wouldn't say, I don't quote 9 to 16% of men have some degree of permanent incontinence in my series. A lot of the slides in this talk were taken from when we did open surgery. Robotic surgery's probably gotten that down to 4 or 5%, but it's still a big number. This just kind of talks about the fact that, taking out the prostate can cause that. So let's just kind of dig into, what can we do about it? Okay, so, the one thing and probably that a lot of people do, and I don't recommend it at all, is they'll really say, well, I'm going to dehydrate myself so there's less pee to leak, or I'm just going to constantly run to the bathroom to try to keep my bladder as empty as possible. I mean, these aren't really great ways to solve these problems at all. And again, I'm going to probably try to say, look, this is a man that's just used to leaking and he's gotten used to it. I can't talk people into surgery, but I do always think it's a shame when people are living with it. In terms of intervention, let's talk about this. And I talk about this all the time. I talked to a patient just today about this. Physical therapy, pelvic floor physical therapy. So if you get on a website of a really huge 30-person urology group or an academic group, they almost always employ their own physical therapists. And so they tend to send everyone for physical therapy for this problem. Again, in men, we're talking about men, the concept of Kegel exercises, which is the rhythmic squeezing of your external sphincter, I'm going to find that to be entirely worthless in a prostatectomy patient because we're waiting for their bladder neck to close. And Kegel exercises has absolutely nothing to do with the bladder neck. We teach Kegel exercises after a surgery because we want men to use them so that they leak less, so they can hold their sphincter while they stand up or sit down. But it's not going to get you out of pads. We use physical therapists for that subset of patients that don't seem to we can't get through to them as to what is their sphincter. We haven't injured it, but there's some people that just don't seem to understand the connection of voluntarily squeezing that muscle. And we ask the physical therapist to teach that patient what is that muscle. But the problem with the physical therapist is they tend to only know about weird exercises that aren't going to help your bladder neck, or they tell you to do, rhythmic, squeeze 30 times in a row. That's what you want to teach women because their problem with stress incontinence is that their vagina is not holding up their bladder. And if you could beef up their vagina or take their vagina to the gym, it can help. It doesn't help much, but it's not a concept that's going to work for men with radiation or prostatectomy-induced incontinence. And biofeedback, again, is the way a good physical therapist will teach you, yes, that's the muscle we want you to do. So you can have this aha moment. But I had a patient today that was still in pads, and I'm sure he won't need pads if he would just go back to doing it the way I wanted him to do it. He was doing it the way the physical therapist told him to do it. So I have not had any times where I was convinced that it's the physical therapist that got someone to stop leaking, but it's helpful to teach them the Kegel exercises. And then coping again, is just frankly something I consider a shame. Penile clamps are just these things you can get on Amazon that just basically clamp your penis. I strongly disapprove of those because, again, if you're doing that, your bladder neck is never going to learn to close on its own, and it's not going to force you to do the Kegel exercises we want you to do. And the reality is that the fix is really easy. And if the fix is easy, patients should know about the fix. They're still allowed to say, I don't want to do it. But most patients don't know what the fix is. And the fix is 2 different procedures. And this market is super duper dominated by the product from Boston Scientific. The penile prosthesis market is also dominated. 80% use the Boston Scientific product like I do. Here it's like 97%. There are competing products, but I've never seen them or heard of them. So the first one is called a male sling, and that's gone through different permutations. In my practice, I'm very choosy who I offer a male sling to. A male sling is not for radiated patients. It just doesn't work. It's predicated on freeing up the urethra, which is the urine channel at the bottom, and making it so it can be puckered into the bladder. And by pulling a sling up, it's pushing it into the bladder and, in essence, creating that pucker that you need. I always say, you're missing a little bit of pucker at your bladder neck, and that this is what creates that. And the tissue is just too scarred and woody to create that pucker with radiation. So this is not for radiated folks. And to me, it's not for people that leak more than 2 pads a day. So, and a patient can leak hardly 1 pad a day. They sometimes can say, I'm only mostly leaking when I have an erection, which is a big complaint. And that's really bothersome to them. So it's not up to me to determine what amount of leakage bothers you. Anyone can have a sling if you're having a degree of leakage that's bothering you, but I'm going to recommend a sling if it's 2 pads or less, because in my practice, 97% of patients, it just goes away, problem solved. We do a sling, it's an outpatient procedure, it's a small incision under your scrotum. You see us the next day, and you're immediately continent and the problem is solved, okay? When one study reported a reduction in pads by 77%, that means they're doing slings on patients with much worse incontinence. And I always say, I certainly used to tell my children, I mean, we're not coming to the plate in the hopes of getting a single. We're in the hopes of getting a home run. I am in the hopes of getting you out of pads and fixing your problem, not lessening your problem. So that's why I want to stick to few little leakage for the sling patients. But if there's 2 pads a day, it means you're still walking around with a pad, you're changing it, it's getting wet. To me, it's a no-brainer to do this. It takes me like an hour. It's outpatient. There's not much pain involved. It immediately fixes your problem. That's usually what I want a person to do. This is just a schematic of how it's done, but this isn't what you look like. Here, there'd be a little incision. There's these 2 little puncture holes in your inner thigh, which allows me to thread it this way. You don't usually notice the puncture holes, and the soreness down here goes away within a week or 2. And I've really had very, very few complications. There's always a risk that you won't be able to urinate the next day. That's usually a great sign. It's like 99%, 100% it's going to work. I've had one patient who just couldn't urinate later. It's a very thick patient, thickest bone I've ever seen as a rugby player. And even he, we did a small procedure to loosen the sling. He's still dry. It still worked. So I think he'd still say he's glad he did it. So not a lot of risk to this. Routine infection, bleeding, etc. That's the sling. But what if you leak more? What if you've been radiated? Then we have to go to what's the more traditional approach. Ironically, a lot more urologists know how to do a sling. Know how to do a sphincter, which is a little bit more of an operation than the sling. And that's just because generally the people that know how to do a sling are going to be urologists that know how to do reconstructive surgery to your urethra. It's a scary place to operate if you're not used to being there. I happen to be one of those people. But it's a simpler thing than the sphincter. And what's the sphincter? The sphincter is basically like putting in a bladder neck again. It's just not at your bladder neck. It's more downstream, but it's going to pucker. It's going to completely close your urethra. It's like a blood pressure cuff that you're putting around the urethra, the urine channel, and it's not air that blows it up. It's saline or water. Same idea as the penile prosthesis. Where does the water come from? It comes from this tiny balloon that we do put behind your pubic bone that you never know is there. And how does it pump up? Well, it's different than the prosthesis where the pumping pumps it up. Here, the default is it is pumped up, and what you're doing is pumping the water out of the sphincter back to the balloon. It's also a big feat of engineering. It gives you about a minute to urinate, which is how long it takes the average older guy to do it. So no one has any idea that you got this when you're standing at a urinal in public. Nobody sees you pump the thing. It's like one pump. It just looks like you're scratching yourself. You urinate, and then it closes on its own. So this is an enormous game changer. No one's going to think they're bionic or weird. Most patients that I've done a sphincter in, they don't even mention it to me when they come back. I have to remember that they have a sphincter because it's just their new routine to urinate. It just becomes them. It also has these risks of infection and erosion. Again, radiated folks are at higher risk, but not a high enough risk to preclude doing it. And this is going to take a guy that leaks 7 pads a day and get him out of pads typically. Maybe he leaks 1 pad. We don't want to do it too tight. But a sphincter also really hits home runs here. Here's the schematic of it. Everything I told you. There's a small incision down here where we insert the blood pressure cuff and make a tiny incision up here to put the balloon in. This will be a left-handed person because it's on the left side. It would be on the right side if you're right-handed. I'm going to try the same tricks. Nope. So again, it's just a schematic that says that here it's full. He's going to pump it. It's going to push it back here. It's going to open. Urine's going to flow, and then it's going to stop on its own a minute later. It's an outpatient procedure. Unlike the sling, we have to make sure we're trying to minimize the risk that there's an erosion. You're putting a foreign body around the urethra, and we don't want it to squeeze right away. We want it to heal. So this one, we send you home deactivated, where it's still open, and then you meet the rep in my office 4 to 6 weeks later, and all you do to activate is you squeeze the pump one time, and then you're dry. And it's probably some of the biggest moments in my practice have been taking someone who maybe went off to some academic place, never knew he could be fixed, leaked tons, and then 7 years later, he gets it fixed. And then overnight, he's dry. I mean, it's usually a big emotional moment for people. This is probably another thing saying patients are happy with it. Of course they are. Now here's the same cost slide. I've never seen an insurance that doesn't cover this. So this is different. I always find it weird, you'll take a patient with a prostatectomy, he had good erections before, so clearly his problem has been caused by his cancer surgery, but that's commonly not covered. But they will see incontinence as a cause that's being caused from the cancer surgery. So here you have nothing to worry about, typically, regardless of your insurance. This is just some happy patient that says great. And this is just an obvious thing saying it's good not to leak in your pants. And again, we're going to look for the words infection, and we're going to look for the words erosion. That's what can happen. Urinary retention is extremely rare. Device failure is generally, the company's going to say, look, you generally get 10 years out of this. The revision of this is a little higher than the penile prosthesis, largely because a guy can live with this for 7 years, but once he sees what it's like to be dry, the minute it doesn't work perfectly, just a little, he says, I want that fixed. So it's funny because people will delay it. But once a person has one in that doesn't work right, they want it fixed right away. It's usually a very easy fix to do. So that's the bottom line. That's the risks. They have their own site, fixincontinence.com, just like edcure.com. I think my site's more where it's at. dcurology.net. You'll see this in extreme detail on my site. You'll see my webinars about this as well. And here's just some regulatory things that we have to go through and some references that we have to go through.
Yeah. Thank you, Dr. Engel. If you could go, yeah. And you can even come back even to full screen if you'd like. Everybody, I'm going to go ahead and stop this recording.